Hello, I'm Doug Musio. This is the first of two City Talk conversations on healthcare. On November 7th, the House of Representatives passed what the New York Times reported on its front page as sweeping healthcare overhaul passes the House. What was this overhaul? Was it indeed historic? Over the next two shows, I'll ask several questions. What's wrong with how we finance and deliver healthcare in the United States? Why do we spend far more per capita on healthcare than any other country and get inferior results? Why have we not been able to fix it so far? Why don't we do what other countries do? And then finally, what's next? With me to address these questions, to separate myths from the realities, are two colleagues of mine at the School of Public Affairs at Baruch College. Shoshanna Sofaer is the Robert Luciano Chair of Healthcare Policy at Baruch. She is an internationally recognized expert in healthcare measurement and improvement, in the development of materials and interventions for healthcare consumers, and in the assessment of medical education programs. Professor Sofaer was honored last year by being named the Lorraine and Ralph Lubin Distinguished Visiting Professor at the Weill Cornell Medical College. Jonathan Engel is Professor and Associate Dean at the School of Public Affairs at Baruch. He's recently published a book, American Therapy, The Rise of Psychotherapy in the United States, which has been widely praised and stimulated debate. He has authored three other books on the historical evolution of health and social welfare policy, and he is currently working on a book on healthcare policy in the United States. Welcome back, Shoshanna. It's been a long time. Welcome back, Jonathan. You've been here relatively recently. Okay, let's start with the first question. The New York Times, sweeping healthcare overhaul passes the House. What does it do, number one? And number two, what doesn't it do?
Well, what it does is extend health insurance to 36 million of the nearly 50 million people in this country who are uninsured.
But not right away. This is not until 2019?
Well, these things always have to be phased in.
Okay.
So the question is, how quickly are they phased in? But you'd want it phased in because there's many a slip between cup and lip, and this stuff can get rejiggered in the implementation process. And so a lot of people are going to have to be watching it if it gets also passed by the Senate. So this is historic only if the Senate passes, if they get together in conference, and then we'll be able to look at it. So it's primarily a bill to increase health insurance coverage for the uninsured.
Okay, Jonathan, you've looked at the evolution of healthcare policy in the United States. Where are we at this juncture?
So let me go to that word sweeping. Is it sweeping?
Go ahead.
So
Is it
right.
historic?
So for someone who's very optimistic and very ambitious, it's not sweeping. It largely preserves our present system of private health insurance. It preserves our present system of private nonprofit sectarian hospitals, of private physician practices, of university-based, government-funded biomedical research. So in every way, our healthcare delivery is going to look 96% the way it does today. This is not sweeping. On the other hand, if you look at the multiple efforts to reform healthcare in this country and healthcare payment going back to 1915 and the American Association for Labor Legislation bills and efforts in the 1930s and again in the 1950s under Truman and then again in the 1960s, nothing happened. Again and again and again, there were efforts to try to reform healthcare payment, and we couldn't do anything. The fact that we've done something, however small it may be, is extraordinary. We haven't done anything for 90 years, with the exception of Medicare. So the fact that something just passed the U.S. House of Representatives on the floor, not in committee, that it actually passed by more than a scant margin, this is extraordinary.
Two votes. Wait a second. I mean,
all right. So it's a scant margin.
Scant
margin. All
okay.
right.
Now,
I think we got a Republican.
Yes,
I think there was one Republican.
From Louisiana. Yes. What does this bill actually do? What are its major provisions? What are its impacts?
The major provisions are actually fairly straightforward. First of all, it opens up the Medicaid program, which I would argue, Jonathan, was another major achievement at the same time that we created Medicare. And it opens up the Medicaid program, which is an existing public health insurance coverage program, to about 15 million Americans. And that follows a gradual delinking of the Medicaid program from the welfare system. So now you don't have to be on welfare to get Medicaid. Right. So that's a big deal. The other is that it requires all but a very small percentage of Americans to have health insurance, and
mandates that you own it.
That you own it,
That's right.
Or you pay a fee up to 2.5% of your income. And then it also mandates that all but a subset, the smallest employers, have to offer health insurance. So there's both what we call an individual mandate and an employer mandate in this bill. And quite frankly, it's been argued that without one or both of those mandates, you're never going to get to universal coverage. So if you're going to do that, you then have to provide subsidies for people who cannot afford to buy this insurance, and and also for the employers who can't afford to pay it. If we think about it, think of somebody who's making the minimum wage, right, of $8 or $9 an hour, for their employer to offer them health insurance and pay for it the way most employers do, where they're covering 75 or 80% of the cost. Mm-hmm. They just doubled their personnel costs.
Right.
It's unrealistic. So there have to be subsidies in the game. What I want to point out, though, is that in addition to that, the big push of this legislation, which is to get people insured. I should mention first, there's a public health insurance option in this bill. And rather than leave it to the states, it's another national program like Medicare. But the deal that was struck was that they're not going to be paying at Medicare rates. They're going to actually be negotiating rates with the doctors and the hospitals. We'll see whether the negotiation comes out any better for providers than it is now. But in any case, that's what's going to happen.
Okay. Now, we're talking about a bill that passed one house. We've got another house. Talk to the bill and then talk to the future.
First, I actually want to go back to what Shoshanna said, and I agree with Shoshanna. What this largely is about is private insurance expansion with this public option. But one thing I hear this again and again, this issue of a mandate. And Shoshanna called this an individual mandate and an employer mandate, and she's absolutely right. What does that mean? It means suddenly it's the law, a little bit like it's the law in my state that you have to have auto insurance. You can't. You can have a driver's license, but you can't drive the car unless you have auto insurance.
Right.
So we have a precedent for requiring people to buy insurance. And a lot of people say to me, well, isn't this government intrusion into our lives? Why should I be required to have insurance coverage? And let me just give a quick answer to your viewers, because it's a very easy answer. If we are going to mandate that insurers must take anyone who knocks at the door, which is part of what this bill is about. It doesn't matter how sick I am. I could be dripping from a bullet wound, and I show up at the insurance company and I want to buy insurance, and they have to sell it to me, and they have to sell it to me at the same price as they sell it to the guy next door who's healthy as an ox. All right?
And the rationale
is that insurance is about risk distribution. You can't be carving people out of insurance because they pose high risk, because then it's not insurance anymore. Right?
Okay.
So if you're going to require the insurance company to sell me something that they will clearly lose money on, I show up in the middle of a heart attack, I demand that you sell me health insurance, they're clearly going to lose money at me, then you have to require people to buy. You have to require them to buy it when they're healthy. Otherwise, no one will buy it when they're healthy. You'll wait until you get sick, and then you'll buy it. And that's why if you're going to require the insurers to treat you like a human being, you have to require the human beings to treat insurance like a viable business. The mandate has to be on both sides. And for some reason, a lot of people don't seem to understand this. You can't demand insurance reform without demanding reform of individual behavior.
Okay, I just want to go back to a point that Jonathan made earlier, that this is not really revolutionary at all in some senses, but in a sense it ossifies a dysfunctional system. Do you agree with that assessment?
Let's put it this way. I wouldn't say that it ossifies it. It's already pretty ossified.
Oh, okay.
But it doesn't do much to change it.
Yeah.
Okay? And that's quite frankly because there's so much wrong with this system that I don't believe that there's any single piece of legislation that could address all of the problems simultaneously. Now, let me tell you, historically, I'm not a historian, but I lived through the Clinton White House Task Force for Healthcare Reform as a member of that. So I've been there and I've done that.
Right.
Right? And we tried to do that. We tried to come up with a bill that addressed cost issues, quality issues, access issues, disability issues, long-term care issues, da-da-da-da-da-da-da. This 1,001, Arabian Nights pages bill.
Which
And
is shorter than the one
Shorter
they
than
have
the
now.
shorter than the
1900
one that they
pages.
had. Right. And it was fascinating as an intellectual exercise.
Uh-oh.
Okay. But one of the comments that was made by Henry Waxman was at that point the chair of the House Subcommittee on Health and the Environment. And his lead staff member, Karen Nelson, said, when you pick up any piece of this bill, the entire bill comes up with it, because we had so carefully knitted everything together that Congress wasn't able to disaggregate and pick out what they wanted and what they didn't want. And that's why Obama went in the direction that he did this time around, of saying, Congress, you come up with it.
Now, was that strategically looking at that? Has that been successful politically, that approach?
I have to say, if you'd asked me in August, I would have said no. I really was very pessimistic 3 months ago. I thought this whole thing was going down. There were these very, very effective ads, frankly, from the far right wing of the Republican Party about death panels, and it seemed to be gaining traction. And I really thought, I thought President Obama had blown it, that he needed to be much more involved and take a much more hands-on approach to the leadership. The fact that this just passed the House, and the fact that the Senate is seriously talking about bringing something to their floor, I've changed my tune.
Well, Obama, I
Right,
mean, personally lobbied the legislators on that Saturday.
But
to
he's
get
been
this
very
bill.
careful to let this
Yes.
be a creature of
Yep.
Congress,
Yep.
not a creature.
And that could be a mistake, given the way Congress operates.
I just quickly wanted to comment on one thing that Shoshanna said, which is the question is this revolutionary or not? And I'll stick by what I said, which is that this is incremental, and I think Shoshanna and I agree. The one thing I would say is the system as it exists right now is so crazy and so screwed up that anything is good. I mean, any movement is good.
This is
Incremental or revolutionary.
That's right.
Incremental
This
or
is
revolutionary.
Rube Goldberg. No rational person could or would develop this total non-system that's fragmented. Okay, let's then ask the first question.
Can I ask a question? Let me just talk
Yes,
about the
okay, go ahead.
presidential thing.
Go ahead.
One of the things that I think people don't remember about the Clinton healthcare reform is that, in point of fact, Obama has been much more verbal and visible in his support of this healthcare reform process than William Jefferson Clinton was.
absolutely.
That's actually
Okay,
a good point.
he gave it to his wife. His wife was fabulous on her feet. She did a tremendous job. She couldn't work directly with us, but he created this task force and appointed basically a megalomaniac to run it. This guy from Ira Magaziner,
Right.
who was his former Rhodes Scholar buddy from England, who knew nothing about healthcare and proved it over and over again. So even though he had the best advice, this guy's problem was it's going to be my way or the highway, and what he got was the highway. And so there was none of the sausage making that goes on in the congressional process was really engaged there, and Clinton did not do the hard work of working with Congress.
Well, clearly the Obama folks learned that lesson because their approach has been so dramatically different. Okay, I mentioned questions at the very top. The first question was, what's wrong with the way we finance and deliver health care in the U.S.? Let's step back from the conversation about the House bill. Maybe we should talk about the Senate, what's coming up in a little bit. What's wrong with the House bill and what's right, to look at what's wrong with the finance and delivery of health care.
So let me start actually with the delivery system.
Go.
Okay. And it's related to the financing system. Financing system is basically fee for service.
Right.
Which means that people get doctors, basically, who run this system.
Right.
Let's get real. Doctors run the system. That they get paid on a piecework basis. Okay.
Which creates perverse
Which
incentives.
creates incredibly perverse incentives to do more. And they have convinced very effectively the American public over the years that more is better and more expensive is even better. And that suits their needs, and it creates incredible incentives. Add to that the fact that we pay different kinds of amounts of money depending on what the piecework is. And right now we're doing it backwards, okay? We are paying a lot of money to the heroic procedural medicine diagnostics, for the MRIs, for the surgeries, for the implantable defibrillators, all of those things. And we're not paying very much at all for what is sometimes called cognitive medicine, which is you sitting down with your physician and the nurse practitioner and the health educator and learning how to manage your chronic condition.
But you don't make money doing that.
That's exactly
Well, the reason you don't make money doing that is because of the reimbursement system.
Right.
The reimbursement system now pays, to use a colloquial phrase, bupkis, to primary care physicians. So much so that nobody wants to be a primary care physician anymore,
Right.
and that's going to further exacerbate the problem.
Let me interject. First of all, I agree with everything that Shoshanna just said. As my grandfather used to say, you never ask a barber if you need a haircut.
Right.
And yet every day we're asking our doctors if we need a haircut,
Right.
And of course the answer is always yes. Should I get
Right.
this? Now, I would start by saying there are many, many ethical, thoughtful doctors. In fact, I would say most doctors are ethical, thoughtful. I would also say that most doctors are human beings. Human beings work hard. They want to make a buck. And I think it becomes
They're
particularly
self-interested
complicated.
actors.
Of course, they're self-interested, like all of us are.
Right.
And it becomes particularly problematic when they can make a buck without hurting you. It may not help you what they're doing, but it's probably not
So
hurting
they don't
you.
do any harm.
Well, they're doing there is actually some evidence that there is
They
some
do
harm
some
being
harm
done by
too, yes.
over-treating,
Okay, no,
because
okay,
there's always
I
risk
take that
implicit
back.
in treatment.
Right,
But it's not
right,
so much
right,
harm.
no, I take
The
it
second
back.
thing, and I'll absolutely agree with Shoshanna, is that people like being over-treated. But there's all sorts of studies done about patient satisfaction. Patients hate leaving a doctor's office empty-handed. In other words, often the correct prescription is do nothing, go home, you'll get better. Patients hate this. Doctors are in business. They have to have satisfied customers. They know that if the patient can leave their office with nothing more than a piece of paper, a script, they will be more satisfied. So it's so we're part of the problem. We go to the doctor, we want the doctor to do something to us, to order a test, to order a prescription, to order a procedure, to order us to go to a specialist, something like this. The second thing I would say, and again, absolutely to back Shoshanna, one of the things that I think Americans are unaware of is the extraordinary discrepancy in income between primary care and specialist physicians. So we talk about rich doctors. Let me tell you something. Pediatricians ain't rich right now. A friend of mine who's a pediatrician said, one of the reasons why doctors are finally supporting health care and health reform is because doctors are no longer rich enough to vote Republican. And this is true for primary care physicians. In the New York area, a basic run-of-the-mill pediatrician is at about the 130 to 150 level. Let's just throw some numbers out.
Okay.
And an internist, depending on how entrepreneurial they are, at the 150 to 175 level. And a geriatrician's in that same place. And a family practice, they don't even exist in the New York area. Up in Vermont, they're at like 115. It's not bad money for most Americans. It's not a whole lot of money given the kind of investment in the career. By contrast, if you look at a procedural-based specialty physician, an orthopedic surgeon, an anesthesiologist, an ophthalmologist, the sky's the limit. We're talking $400,000, $500,000, $700,000 a year. A cardiothoracic surgeon can bill $1 million.
Send your kids to med school.
So one thing
And
to be aware of when we
specialize
look
in
at the
surgery.
system is to realize, and I want you to think about this for a second. To become a doctor, there's 4 years of college, 4 years of medical school, and then 4 years of residency. So you've already put in 12 years to become a pediatrician. If you put in 3 more, you're an orthopedic surgeon. So you've already put in 12 to make 1 1/4. Now with 3 more, you're at 650. What kind of an idiot doesn't do the extra 3? You'd have to be extraordinarily idealistic, or extraordinarily adverse to blood, or have a great trust fund. But no rational 27-year-old is going to pass on the last 3.
Okay, so we've got these perverse incentives, these irrationalities. If you're not paying a fee for service, what do? Pay a fee for health? Can we measure what health is and then pay for that?
Actually, we can, but that's
that
not
the
what I would
answer?
be proposing.
Oh, okay. I'm not the
there-
health person.
The issue here is that we need to stop paying for piecework and we can start paying for outcomes, but that's very difficult and we don't know enough yet to be able to do that. But on the other hand, managed care got a very bad name a number of years ago. And it got a very bad name because people viewed it as keeping them away from the doctor of their choice and keep putting them into a system that would not overtreat them, that would send them home without
Right.
a script, or would send them home with a script, but it was a generic script and not a script for
Them.
The
advertised brand name
Right.
that was being
Right.
floated at them. So I happen to have been a patient at the probably most highly integrated delivery and insurance system in the United States, which is Kaiser. Okay, I loved being a Kaiser patient. I've loved being a managed care patient, because the alternative fee-for-service patient, if you've got anything really wrong with you and you've got multiple things going on, you're going to 5 or 6 different physicians that are telling you 5 or 6 different things. They don't know what each other are doing. You're the one who's ending up having to coordinate your care. You don't, unless you take initiative, they don't even know what each other are prescribing for you, and they could be interacting negatively. And you're going from pillar to post and from pillar to post. At Kaiser, you have your primary care doc. Primary care doc makes referrals to specialists. Everybody hated this in managed care, but the reality is we do it in fee-for-service too. So what we need to do is be paying for a defined population of patients on a what we call per member per month basis, so that you're taking care not just of a bunch of individuals, but a population of individuals, and you're making your decisions on the basis of looking at that population.
Okay.
Now, the problem with that is that people don't want to be looked at as part of a population.
They want
to be looked at as unique individuals. But here's the deal. I don't know that we can afford that. I don't know that we can afford that. Maybe we can if we stop spending millions of dollars on technology and super specialties with marginal benefits. I'm talking marginal benefits. Doing something that costs $700,000 and maybe buys you 6 extra weeks of life, and the quality of your life during that period of time is not wonderful. It's crazy. It's crazy.
Nice.
It's not.
A little Yiddish.
It's a non-rational system. I'm not saying it's irrational. I'm saying it's non-rational.
Okay.
Can I
Go.
add? And to add to what Shoshanna said, we actually began to move very rapidly into managed care, ironically, right after the Clinton health reform failed. So it was right around 93, 94, 95. Whereas in the late 80s, only 5% of the country was in managed care. By about 96, something in the order of 70 or 80% of the country which had health insurance was in managed care. This was the interesting thing. The original vision for managed care was HMOs. It was a Kaiser. And the Kaiser model actually does work.
It works.
Exactly what Shoshanna said. What was interesting to see was that Americans hated HMOs so much that as soon as you offered them an option, and the option was usually either what's called a point of service plan, a POS, or a PPO, which is what most of us are in today, almost anyone who could afford it opted up to the PPO. The PPO is always more expensive than the HMO.
And PPO stands for what?
Preferred Provider Organization.
Okay.
That's what most of us are in today. It's
Okay.
fee for service. You get to pick, and then if you go out of network, you pay a little more.
Right.
Actually, sometimes you pay a lot
Right.
more. What was interesting was it wasn't just the wealthy people who popped up from the HMO to the PPO. They said, well, the HMO I only pay $60 a month premiums. The PPO I've got to go up to $300 a month. You say, well, your wealthier employees, your executives, your partners, they're going to pop up. Everyone popped up. Anyone except the very poorest American said, I'm willing to pay the extra $300 a month to get out of this network.
Okay, now wait a second. What I'm hearing from both of you is that this requires not only organizational and fiscal reform, but really a change in culture. Not only the culture of the providers, but also the culture of the consumers. That's what I'm hearing.
Well,
how likely is this?
Part of this is that we do everything now to keep people protected from the financial implications of what they do. Most people that have insurance have the kind of insurance where they pay only a portion of the premium.
Right.
Here's an interesting fact. When you get your pay stub every bi-weekly, if you're a CUNY employee, it says what you have contributed to your health insurance premium.
Right.
It doesn't tell you what CUNY has contributed.
Right.
So you never know what the actual total bill is that's being paid. I have worked with citizens in New York City and gone through with them what healthcare actually costs, and they're shocked because their perception is it's costing me a lot. Then you have to educate them about the fact, not just costing you a lot, honey, it's costing us a lot of money. And everybody is paying for it. And we don't have at all that kind of sense. We don't have the information about how much it's costing overall. And we don't have the sense that somehow that could actually affect us in an indirect or a direct kind of manner. Like, we're paying for a lot of care for uninsured people. And it is not Santa Claus that's paying for it, okay? And Uncle Sam means us, you know? And so we really do have to get that kind of issue dealt with. Now, some people argue that what we need to do is have consumers have more, quote unquote, skin in the game.
Right.
And what that means is they have to
They have
pay
a lot
more.
of skin in most of the
Right.
game, but we're not
But
going
we're
there.
not going. What
Got
they
it.
want, what that means is they pay more co-payments, right? The way that they've structured these things, it's not a long-term solution. Because one of the things that we really need to recognize is that only about 20% of the people in this country are generating about 80% of the cost.
Okay, let's just stop there and
Okay.
just sum up, in a sense, what we've seen. We've seen that the House bill goes only so far, really concretizes, if you will, ossifies the current system, preserves the worst features of it, the perverse incentives, the culture of both doctors and patients.
Overconsumption and overprovision.
And
Both sides.
overprovision.
It's doctors
Okay.
pushing and it's consumers wanting. It's both.
Okay, let's stop here, and then next week we'll talk about these other questions that we've raised. So, this has been the first of a two-part conversation on healthcare and delivery in the United States. My thanks to Shoshanna Sofaer and Jonathan Engel for shedding light on providing, financing, and regulating American healthcare. Join us for part 2, where we have more questions to address and hopefully provide compelling answers. Hello, I'm Doug Musio. Let us know what you think about this show. You can reach us at CUNY.tv. When you get there, click on the bar that says Contact Us and send your email. Whatever it is. Thanks, no thanks, obnoxious, do it. Send it.